Good morning, everyone. Extremely sorry that got the taste of Mumbai's traffic today morning, and thank my team for taking up the initiative and starting the session on time. So thank you all of you for joining us this morning. So after a long time, we are having a physical conference in this wonderful convention center, and this is my disclaimer. I'm with NABH as a honorary principal assessor. Right. As you all know, most of our eye centers are under-equipped, unprepared for the surprises, and not really having an ambulance or transfer arrangement, what Gagan mentioned in his presentation, and inadequate team strength. So even though medical emergencies are rare events that occur in eye centers, but if encountered, these events require immediate diagnosis and management to avoid potential consequences. Mainly, we have to be prepared to save a life, and most important is do not panic. The patients and attenders will be in a panic state, so we have to be prepared to encounter medical emergency at our clinic, and this is part of patient care. So it's not only ophthalmic or so now it is glorified compartmentalized specialization care in most of our medical setups, but this emergency care is the most important aspect of patient care. So why should we learn these things? An important benefit CPR can give you is the ability to save lives during that golden hour. And what do we get out of this? We get these situations create a hero out of you, because this is beyond the call of duty. It can save yourself and your practice, and it can empower your team. And for the hospital, having a certified BLS staff or team is very important, because they are confident attending to medical emergencies. The transfer process takes less time and reduce incidence of medical legal challenges, which we are all worried about. Even yesterday, there was a court case with compensation of over 1.25 crores on the physician because of negligence. So this, when you are prepared, you can have a happy team and happy patients. So this is the crux of this instruction course. I should have started with introduction and followed with, we have with us Dr. Atiq Sheikh, who will be talking to us about how to assess a patient plan for daycare surgery in the eye centers. Dr. Jayanthan will be talking about the equipment and training required for emergencies and code blue drill. And Dr. Gagan has already spoken on NABH standards on acute care emergencies. And Dr. Kumaran will be talking to us about some case studies and videos, how he managed emergency in his eye center. And finally, if you are not prepared or some eventual things happen, we have to manage the situation and the crisis. So that is important, managing the public, press and police during emergency and medical legal crisis. So that is the last talk. So when you are encountering emergency patient, not only ophthalmic emergency, we are well prepared, but if it's a general emergency, most of us are not well prepared. So we need certain preparatory mindset for that. So we need to assess the patient immediately, and most of us are well trained in the undergraduate and CRRI time for this, but after we come to ophthalmology, we lack continuity. So we have to know what are the equipments that would be useful during emergencies. How should we take a decision? This is very, very important, decision making of transfer and shifting the patients, and how to communicate the bad news with the patient attender, because we have either a group or a big group of patients attenders who will be waiting to hear from us. So first and most important thing is how to sense and save a sinking patient in the OPD. Right. So most of us run daycare centers. We don't know the patients very well. Some of our review patients we would know, but we have to train our team to understand this. So I start with few stories. This is a 35-year-old lady who came for an incision curettage for a chelation. It's a small procedure, OP procedure. We are used to doing that. And so as part of the regular protocol, injection xylocaine test dose was given. And story 2 is about Mrs. X, who reported to the reception with a scheduled appointment. She was seated in the waiting hall. The OP got delayed, as that happens in many of our centers. So after 20 or 25 minutes of waiting, she is restless. Said, "I'm not well, how to see the doctor?" So what the usual response is, "We'll let you in, please wait, madam." Right? So she was made to wait politely by the receptionist. And this third story is on a busy Saturday OPD. A 50-year-old gentleman waiting in the OPD for a regular follow-up visit suddenly became agitated, starts verbal abuse of this staff, started sweating profusely, have tremors. So what do you do in this situation? And this fourth, usually most of us are familiar with, 89-year-old male posted for cataract surgery, very anxious patients, and the BP has gone up to 180, 110. All types of local anesthesia given, topical, intraocular, peribulbar, all those things. Still the patient is restless. So these are 4 situations we generally come across, and how do we tackle this? So back to the first patient. This patient started itching and suffocating after the injection. So injection test dose was given. And so on assessment, these are the vital signs: 124 per minute, 35 respiratory rate, and the oxygen saturation was coming down and BP was falling down. So patient was awake, oriented, the breathing was fast, tired, hoarseness of voice. So generalized flushing noted. So what do you think of this? Yes. So these are some of the hints to the diagnosis. So sudden acute onset, secondary to a trigger. Here the trigger was the injection xylocaine test dose. Sense of impending doom. Most of our patients who have this problem tells this, and the change in the voice. So they can't speak, so they have this rapid change in the consciousness level. So anaphylaxis, as we all know, is a potentially fatal. We have to be on our toes. It's a multi-organ system reaction. As ophthalmologists, we are not oriented to this, but we have to immediately diagnose this and start therapy, because once you start, treatment is the most gratifying treatment for a doctor. So is there any time for investigation? What investigation you will do? No. So this is the clinical diagnosis. So this is where our clinical experience comes into the picture. Investigations are not helpful. In fact, it will delay the care process in the acute setting. So how do we recognize? It's not always easy to recognize, but you have to be hearing these kind of stories. History of recent episode of anaphylaxis, sudden onset, the suddenness of following the injection. It can happen after few hours also, usually affect more than one system. So test dose, most of us we do give, but we have to understand the minimum dosage, not only test dose but also the minimum dosage for local anesthesia. If you are giving LOX, only lignocaine, 7 ml is the highest limit. Other than that, more than that, you will experience pressure on the orbit. And if you are using a combination of xylocaine with adrenaline, don't give more than 17 ml. And if you are using bupivacaine, don't give more than 20 ml, because two important things: there is no standard guidelines regarding usage of local anesthesia test dose, and the allergy can happen to the drug as well as to the preservative. So most of this bupivacaine will have preservative, and also there will be cross reaction. So just because you have cross allergy with xylocaine, people tend to use bupivacaine. So cross reaction is possible in these group of drugs. You have to be aware of this. So initial steps in the management of anaphylaxis, you have to focus on this A, B, C. So airway management is very, very important. So you have to, this is the key initial intervention. So you have airway tubing, you have to start using that, and also have injection adrenaline and injection hydrocortisone I will given, and supplementary care, oxygen, cardiac monitoring, IV access, position the patient comfortably. All these things your staff have to be really trained well. So Dr. Jayanthan will be talking about it. Then if you have the facility, you can have treat the patient there itself, or so in the simultaneously you have to transfer the patient, call for the ambulance. So back to our second patient. So patient was presented with classical symptoms of cardiac arrest: sweating, chest discomfort, upper body discomfort, nausea, lightheadedness. So what happened? So we called code blue, what Dr. Gagan was telling. So code blue is one condition where we secretly, silently convey to our team that there is a medical emergency, cardiac emergency. So during this time, our staff recollected their training and activated code blue, the receptionist called. So all the training situations came into the real time situation. So cardiopulmonary resuscitation was done, and patient was non-responsive, no breathing, no neck pulses. They started CPR. So this is we call it running the code blue, and after initiating CPR, patient was transferred to a nearby hospital. Luckily, we had a hospital in our street itself. Patient was admitted in the ICU. So the third patient who was in the on a Saturday busy OPD suddenly falls to the ground with hands on his head and sweating after the verbal interaction with our staff. So then, so is it a emergency? Again, we have to do all these things. So quickly do a blood sugar. Since the patient was known to us, we know he was a diabetic. We did the blood sugar CBG. It was 62 milligrams. So what do we do now? So it's very important that we recognize and manage. So the simple treatment here is, this is the blood glucose level, and this is very, very important. Around 120 you can manage with simple oral solutions. If the patient is conscious and can take oral fluids, so it's always better to give dextrose or any sugar based solutions. So even tea, coffee, whatever is available, that's okay. But if it's below 80, you need immediate hypoglycemia have to be reverted, because the patient can go in for altered mental status immediately, along with the then we can also go for hypoglycemic crisis if the patient has already taken insulin or any anti-diabetic drugs. So if the patient is not able to eat, you have to secure the IV line, start pushing dextrose 50% IV bolus, and then monitor the blood glucose every 30 minutes. Most of this hypoglycemia, if you have a good well-trained team, you can manage. If the staff is well trained and oriented to identifying hypoglycemia, this can be managed. So most of us, we are confident about managing hypoglycemia after about 2 or 3 episodes in our hospitals. So this is the fourth situation, which is quite familiar in most of our daycare surgery centers. We have a anesthesiologist all the time for any type of surgery. So the patient anesthetist noted that the patient is not settling down, and in fact with so much anxiety the BP is going up. So he gave IV midazolam, sedated the patient. The BP came down to 130/90. We continued with the surgery, and this is called as monitored anesthesia care, or MAC, which is really useful in many of our under-equipped centers. So debriefing, medical emergencies can happen anytime, any day, in any center. So how are our patients now? This is what happened to the first patient. Patient settled in 4 to 6 hours time from the anxiety as well as from the anaphylaxis. The BP got settled, patient was happy, was discharged on the same day, and the attenders was really very happy that we managed the situation well. The second patient who suffered a cardiac event, recovered in the ICU, treated medically, and now he is on my lifestyle modification as well as cardiac care. He is doing pretty well, and also happy to give so much good comments and also refer his friends. So these are events that can really give you not only save lives but also happy patients, and our team is extremely happy that all this training didn't go waste. So common emergency in daycare center: hypoglycemia, anaphylaxis, particularly during FFA. The drug is a potent source. The asthma exacerbation can happen because of the suffocation in the OPDs or closed settings. Most of our rooms are dark, small rooms. So this can exacerbate asthma as well as claustrophobia. Seizure attacks can happen, impaired consciousness, or pain shock. Even an injection can give pain shock. And of course cardiac arrest, because most of the time we are dealing with elderly patients. So there are many ways of being sick and defining critical illness. This is not the time and place to define illness, but how do we prepare our center and our staff? This is very, very, very important. So in the reception, we need to have some intelligent reception, and when they inquire, the staff have to understand from the patient perspective, check the vitals. So if you have a triage staff that will be very good to check the vitals. And also we need to have a CCTV to see what is happening in the reception, and train the staff to identify abnormal vital signs. If they are deranged, they have to immediately call the doctors or the trained nursing staff. So these are some of the normal vital signs we have to teach our staff that. So even the non-medical staff like optometrists or the technicians, the receptionists, we have to teach them. So overall, in emergency situations, so there are red flags. You have to identify the red flags. Initial assessment have to be important, documented, and has to be done as soon as possible. And intervention have to be as early as possible. Diagnostics can wait, so you have to reassess, communicate with the other team members as well as with the patient attenders, and keep on helping the patients. So this is the overview of what you do in the emergency phase and non-emergency phase. Once there is an outbreak or a case, you have to follow these norms, and also document all these things. As Gagan said, you have to document it and see what is lacking in the emergency crisis management of our center, and see whether it could be improved, and all this have to be documented. So nothing can replace the skill, abilities, and knowledge that is spent in preparing the team for the teamwork. And these are some of the reviews that it can really help. And so patients are very conscious about this, what you emergency situation or centers, facilities you have in your center. So they are not seeing only the infrastructure, the aesthetic point, but they also see the preparedness of the staff in managing emergencies like this, and they do give this such wonderful feedback. So care starts at the doorstep. Vitals are very important. Know your patient. If it is an old patient, try to understand and know your patients during the registration itself. Equip well and train the staff. Knowledge, skill, and teamwork is very, very important in managing this crisis. So problems do happen, but they are not stop signs. They are guidelines if you take it appropriately. Thank you so much.